Thank you so much for that introduction. I'm so excited to be here. And this is one of my favorite courses to present, primarily because there's not as much awareness around this topic as there needs to be. And I honestly think that if we can just keep spreading the word and we can keep educating everyone about Airway and about how detrimental it is and everything else that you're going to learn tonight, we can really make a difference. I am an international speaker. I'm the director of education for a company called Biome. We'll be launching next week, so watch out for that. We've got some really great stuff coming out for you guys. I am a published author. I am a dental hygienist. I've been in the dental industry for over 11 years, and education is my passion. I will definitely be paying attention on my other screen over here at your questions, at any Q&A that you have. I prefer this to be as much of a conversation as possible, even though I'm not in front of you. So please do not hesitate to ask me questions. I'm going to go ahead and dive right in. And also here at the bottom of this slide, you can see where I've put my Instagram on there. Please, if there's anything you find knowledgeable throughout this course, go ahead and post it on your story, tag me in it, and I'll reshare it. Like I said, the faster we can get the word out, the more lives we're going to save. So this is my why. This is a picture of me sleeping with my mouth wide open. This was probably about 7 or 8 years ago, roughly. And the whole thing behind this is you don't know what you don't know. My parents did not know that this is not cute, which is why there's so many pictures, even when I was a little kid, where I'm sleeping with my mouth wide open and they would catch a picture of it because they thought it was adorable. And really what it was is I was exhausted. But it's not their fault. Their physicians didn't tell them, their dentist didn't tell them, no one educated them. They definitely weren't being taught if they were visiting my school or anything like that. So it's not their fault. It's no one's fault. But what I'm going to do today is make sure that you do know so that you can spread awareness and educate everyone.
When you breathe, air travels down your throat, through your windpipe, and into your lungs. The narrowest part of that pathway is in the back of your throat. When you're awake, muscles keep that pathway relatively wide open. But when you sleep, those muscles relax, allowing the opening to narrow. The air passing through this narrowed opening may cause the throat to vibrate. That causes snoring, which many people experience. But in some people, the throat closes so much that enough air can't get through to the lungs. When this happens, the brain sends an alarm to open the airway. Most often, this is associated with a brief arousal from sleep. The brain quickly reactivates the muscles that hold the throat open. Air gets through again, and the brain goes back to sleep. This disorder is called obstructive sleep apnea.
That video is one of my favorites to start everything out because it's really important for you to be able to see, but also be able to have the knowledge of what this looks like in the terms of anatomy and what is actually happening to us, our patients, our family members, everyone, when they're having these choking episodes multiple times an hour throughout the entire night. This slide that you see in front of you, definitely go through and ask yourself any of these questions. Do you snore? Do you experience daytime sleepiness? Any of these questions, even if you can't answer yes to, I'm sure that you know someone who can, or even that one of your patients can. If you're not currently screening for OSA, then you're missing these patients every single day. If you practice clinically this week, you probably miss dozens. And all the time I get asked, it's kind of a marketing question. They're like, well, where am I going to get patients? How do I recruit patients? How do I find patients? I'm like, you don't have to. The patients are already in your chair. It's, are you going to treat them or not? Are you going to save their life? Speaking of saving lives, this is just a small and very high level breakdown of how you and your team are going to help save a life One of the biggest things here is you're going to obviously prolong their life. You're going to give them increased energy. One of the biggest things that we see, and it's actually one of the leading causes of divorce, is they can't sleep next to each other. They're not compatible in terms of sleeping next to each other at night in the bedroom. So getting them back in bed with their partner. And of course, we're going to also reduce the risk of heart attack and stroke. Obstructive sleep apnea actually raises their risk of early death by 46%. So these statistics are huge. It's something that we're missing every single day. Going through the American Academy of Sleep Medicine, this is essentially going over and saying that they recommend that sleep physicians prescribe oral appliances rather than no therapy at all. So for adult patients, you definitely want to make sure that they request treatment of primary snoring or anything like that. So this is now our responsibility. Again, the ADA here, it's talking primarily about this slide, and throughout this presentation, if there's anything that you think that you want to share with your team or just share in general, please don't hesitate to take pictures of these slides. And also, I will send you the slide deck if you would like to see it and share it with your team or whoever as well. But this one is essentially going over how dentists are encouraged to screen patients at a minimum for SRBD, which is a sleep-related breathing disorder. So at the bare minimum, if you're not going to treat it, at least screen and refer. This one is primarily speaking for children, going over that screening, going through the medical history, going through a clinical examination is going to help identify in those detrimental years of when they're like everything is forming. It's if someone would have caught this for me when I was a child instead of, my parents not knowing, I wouldn't have grown up into a female with upper airway resistance and also a full-blown obstructive apnea problem. So catching this in the catching this in the early years when everything is forming is going to be critical. I'm going to dive right into more of what the sleep cycle is, what this looks like. And I'm also paying attention to the Q&A over here too. So if you look at this chart, you see that there are technically 5 stages of sleep. And they go into a specific order, but also what a lot of people don't know is if your sleep is disrupted at any of these stages, you don't get to go to the next stage. It has to start all over again. So if you have an arousal in stage 2, and it's not the good kind of arousal, it's the one that wakes you up from choking, then you start all over. You go through this process. You go back to stage 1. You're not going to get deep sleep. You're not going to get REM sleep. And I'm going to go through here in a minute and explain how crucial and why it's so crucial that you do get those stages of sleep. So this is what a quote unquote choking episode looks like when it's broken down into what's happening every time this happens per hour. So you start to fall asleep and the airway relaxes itself. Another thing to note is when you're testing your patient and you want to screen them for their mall and potty class, which I'm going to show you in just a minute, I'm going to give you some tips on that because a conscious airway is always going to protect itself. So you fall asleep, the airway relaxes or it doesn't. You either have a garden hose for an airway or you have a fireman's hose. And when you think about it, a garden hose, when you take the water out, it holds its integrity, it holds its form. With a fireman's hose, you take the water out and it closes shut. This is as black and white as that. It either is going to hold its integrity once you fall asleep and all the air is taken out, or it won't. If it doesn't, the airway is then going to become blocked. Your breathing is going to stop. Your blood oxygen drops. Your heart starts to struggle. It's that fight or flight that's starting to happen. And where you see that arrow with a red circle going around it, your body has 2 choices when it's in the middle of this episode like this. It can either wake up and notice that something's wrong and you start this all over again, Or sometimes, unfortunately, the body has done this so many times throughout the life that it only has one other choice. And it's in that moment, the easier choice for the body, which is a heart attack or stroke. So past that, if you keep going, the brain notices that there's low oxygen. It decides to wake the body up. You wake up, you're gasping. If you've ever woken up in the middle of the night and your heart's racing and you're like, was I chased by a bear or something like that? No, it's likely that you were just going through a choking episode and your body was in fight or flight and it saved your life that time. Then you're going to start to feel normal again and your breathing will slow back down. You'll fall asleep and it's just this endless cycle. Some patients have these episodes 50, 60, 70 times an hour. We're going to dive into snoring next. And a lot of our patients think that snoring is not a big deal. Or for our female patients, I like to ask them because they always say no to snoring. They get embarrassed. I'm like, okay, well, do you purr? And then, they laugh, they open up a bit more, but snoring kills people every single day. And there's so many ways that we can help identify it and not do more harm than good. But essentially, there's 40% of adults over 40 who snore, and that's approximately 87 million Americans. It's a huge number.
I didn't know I had sleep apnea. My mom told me I had sleep apnea. I was asleep at her house about 6 years ago, sleeping in the guest room, the same way I always do, just like this. Ha. Ha. And I woke up, my mom's at the foot of the bed like this. Oh my God, Jose. You're dying. I go, Mom, I'm not dying, I'm snoring. Joseph, that is not snoring, you look like this. Joseph, you have to go to a doctor and get that checked out. I'm telling you, you're going to die, and I don't want you to die, Joseph, because I'll die of heart attack if you die. Oh my God, Joseph, get that. Mom, I'm not gonna go to a doctor for snoring. How long are you watching me? That's creepy. And I kicked her out. Get out of here. Get out of here, Mom. I'm sorry, Joseph. I did not mean to startle you. It's just that I was walking to the kitchen and I heard a noise coming from the guest room. It sounded like someone was killing a bear. And I was like, I don't have a bear.
One of my favorite mentors, Dr. John Carollo, shared that video with me a couple of years ago. And I think it's a great one because it just shows you the mentality that our patients have. It's, I only snore. It's not a big deal. It's not killing me or anything like that. And it's like, yes, it's slowly killing you every single night, actually. And it's an alarm going off. So this is a big statistic, and I'm going to give you a few, but as you can see, 26% of adults between ages 30 to 70 have sleep apnea. That's huge. We go into, again, with the bed partner and what they struggle through. Over 70% of the time, loud snoring is indicative that there's an airway problem. The louder it is, the higher chance that it's actually severe on top of that. And of course, you then cue the most prescribed fix to snoring, which is going to be a flat plane splint, or otherwise known as snore guard. And again, like I said earlier, you don't know what you don't know. A lot of us are not taught this in school. It's starting to get better, but unless you take a CE course or something of that nature, you're not going to know that as a clinician. You think that you're doing something good for the patient. And that's why you're here, to learn that you can actually make the problem worse. You're essentially putting their airway on a skating rink. As you can see here, the teeth are now not having to fight anything like the other side of the tooth structure on the top. So the airway is now just struggling all night long, and you're making it even easier for it to collapse. On top of that, if you're just treating snoring, it's basically like putting a patient in a snore guard is equivalent to taking the batteries out of your smoke detector when it's beeping because it's getting on your nerves. and you want to make your patient happy. So you put them in a snore guard so that they can sleep in bed with their partner again or something like that. But here's what I want you to think about. The noise is gone that gets on your nerves, but what about the smoke and possible fire that caused that alarm to go off? When we do this, we're creating what's known as silent apnea, which is where the term silent killer comes from. Less than 10% of obstructive sleep apnea patients suffer. And this is the biggest part. So 10% have not been diagnosed. So this needs to be fixed. Sorry, guys. But that's primarily because we don't know what to look for. We're not taught what to screen for. And even then, once we are, we're scared that we're going to do something that's going to make it worse, and we don't want the liability. But the biggest thing here is I encourage you to educate yourself and at least at the bare minimum, screen and refer to someone who's willing to take on that responsibility. Don't just stay quiet. Educate the patient, point them in the right direction, and at least try to help save their life. 90% of humans that are suffering from OSA don't know it. It goes into, again, the numbers are just staggering, and it still blows my mind. We're going to go into more of the types of events that are happening during these choking episodes. And I do want you to use the word choking, because a lot of times patients are like, okay, well, I'm snoring, or I'm not snoring at all, so I don't have a problem. Actually, it could mean the direct opposite. If there's no air, then of course there's no sound, because there's nothing for the vibrations to bounce off of. That could quite literally mean that you are having a full apnea event, which it means that there is a complete loss of air. So of course, there's not going to be any sound. We're going to use the AHI to basically bill for insurance, and we're going to use what's called the RDI to treat the patient. So how to get these numbers of how many events are happening throughout the hour is you're going to take the apneas and the hypopneas, and then you're going to divide that number by the hours the patient slept. So when a patient has an apnea, which means that they're completely without breath, they're literally suffocating, but there's a couple of other types of apneas or OSA. You have your obstructive sleep apnea, you have your central sleep apnea, which is a mixed apnea. And it's where your brain forgets to tell you to breathe. That's something that we can't treat as dentists. And then you have your complex sleep apnea. So it's going to be a combination of both, but also even once they're put into a CPAP, so continuous positive air pressure, they're still having OSA or choking events with that positive pressure. It's very rare, but it does happen. One really good thing to help with talking to your patients, especially if they're hesitant, and it's hard in dentistry. Our patients don't trust us a lot of the time, or they think doc's trying to buy a new Benz or something like that. And there's little things throughout this presentation that you can use to your advantage to help get the patient to understand, I'm just trying to save your life. This is the new highest standard of care. That's it. So telling them something as simple as this: you can go 3 weeks without food, you can go 3 days without water, but you can only go 3 minutes without oxygen. So earlier when I was talking about a relaxed airway, so a conscious airway will protect itself. That means it will stay open. So when you're testing for a Malin potty, which is what you see in front of you, you want to test the patient sitting up. Because if you lay them back, and I know it doesn't make sense because that's how they sleep, but they have a conscious mind. So that airway is going to be like, oh, I need to stay open, and you're not going to get an accurate representation of what it actually looks like. So keep them sitting up, tell them that you want them to open as wide as they can without straining themselves, and stick their tongue out as far as they can without pushing it out or forcing it out. It just needs to relax and hang there. So if I look down your throat and I see a class 3 or a class 4, if I can't see down your airway, you can't breathe. It's that simple. Another thing with AHI which is your apnea hypopnea index that we talked about just a minute ago, you can see these different stages over here. I know they say mild, moderate, and severe, but what I want you to do instead is refer to them in stages, because if I say you have stage 1 sleep apnea, your mind goes to cancer usually, or something more serious. And the reason for that is there's nothing mild about choking. Some of these patients are only choking and their AHI is like 5 or 6, but they're desaturating to 50, 60, 70%. That's just crucial in knowing. And that's why we're going to use the RDI to treat the patient. We're going to use the AHI to bill insurance. So essentially what this means in the AHI is insurance is going to mild, moderately, or severely cover it. So jumping into the RDI, which you're going to use to treat the patient, it's your respiratory disturbance index. So it's your combined number of apneas, hypopneas, and RERAs, which we're going to talk about next, per hour of sleep. So your RERAs are going to be your respiratory effort-related arousals. And again, it's not the good kind, but it's an event that causes the arousal, causes you to wake up, and it causes a decrease in oxygen, but it doesn't qualify as an apnea or a hypopnea, which means insurance isn't going to cover it. However, I still want you to treat the patient, because essentially who you're looking out for is me. Your upper airway resistant females. What this is almost like an elephant is sitting on their chest. It's extremely hard for them to breathe. Less oxygen is still as critical as no oxygen. And if your patient is then still, a little hesitant, one thing you can do is a nose test. If you take a deep breath in, close your mouth, take a deep breath in through your nose and release it out. And then take your 2 pointing fingers, push down on right here on each side of your nose and pull down. And then close your mouth, take another breath in through your nose and let it out. If that felt easier once you pulled down on each side of your nose, that's indicative that you might have an upper airway problem. When I say you're looking for patients like me, this is my sleep study. A couple of things that are big here that you see, if you look at my AHI, especially in REM, it's only 8.2 events per hour. If you look at my RDI all night, it goes up to almost 18 choking events an hour. And what's more is my oxygen, if you see over here, it goes down to 91 certain times of these episodes. If I were in a hospital, they'd be running into my room with a crash cart, but there's no one there with a crash cart when you're sleeping in your own bed at night. Another thing that we found out here is my heart rate is going up to 104 all the time throughout the night. It's literally my heart in overdrive, like I'm being chased by a bear when I'm supposed to be repairing and restoring. These orange lines that you see right here are how loud I snore or purr for my funeral attendees. I sometimes snore like a freight train, and the higher this goes, the louder it is. But you read this going down. So you have your respiratory events, you have the body position you're in and how loud you're snoring, your oxygen saturation, your heart rate, and then the stage of sleep that you're in when all of this is happening. This is usually the other side of the report. It tells you how long it took you to fall asleep, what percentage you're getting of the sleep stages. We ideally want this to look pretty even, or at least 25% REM. A lot of times, even if the patient doesn't have OSA or doesn't have an airway problem, what we see is this light is taking up almost the whole graph. So the problem there is they're still not going into the stages of sleep that their body needs to repair and restore itself. If you have a resistant patient and they've seen the home sleep test, that you've educated them so much, you feel like you're going to pass out, take one of the O2 readers. They're small. You can buy them on Amazon and have them put it on their finger and tell them to watch the percentage, hold their breath, and tell them to stop when it goes down to whatever their desaturation percentage was. If it moves, it's going to move maybe 1%, and they're going to turn red in the face and probably feel like they're going to fall out. It shows them, hey, how long do you think you were holding your breath for your oxygen to desaturate to 60? It makes it real for them. It creates that urgency. Another thing you can do is called the straw test. So basically you want to take something as small as a coffee straw, something very, very, very constricted, have them put it in their mouth and try to breathe through it, have them plug their nose, and they're going to feel in that moment how hard it is to breathe through something that constricted. It just puts into perspective how much their body is struggling, sometimes 50, 60, 70 times an hour all night long. So the next section of this is we're going to go into how do we save a life through treatment. One thing about this course and what I try to do the most is to make sure that I stay away from bias and politics. And I really think that we kind of went in the wrong direction when we started this. We all went into how can I make the most money off of this? Who has the best therapy? Who has the best solution? And we completely forgot to educate our patients and educate the public. So now we're having to go backwards and educate the world that it's even a problem instead of just going straight into the money. So what I want you to start thinking is it's not about how much each therapy is going to make you, it's what will the patient be the most compliant with? That's what we need to pay attention to. And quite frankly, with something as serious as breathing versus not breathing, you need to be able to give them every single option. Just because someone needs a CPAP, it doesn't mean that they're going to be a good candidate for it because they're not going to wear it, or they're embarrassed, or they wear it half the night and they take it off in the middle of the night, which is extremely dangerous. If you ask any ER nurse when they have the most heart attack and stroke come through the ER, it's between 4 and 6 a.m. So just think about all these things that start putting it into perspective, start making sense and connecting all of these dots. With the oral appliances, this is a good option for a patient that may not be tolerant of a CPAP or literally just doesn't like the way that it looks, and they sign a CPAP intolerance form and they click other and they, say, I don't like the way it looks. Okay, we send that off to insurance. Now they can get an oral appliance even if they're a severe patient or a stage 3 patient. This is going to take your mandible, your lower jaw, and advance it forward. And sometimes we have to open you up a little bit vertically. I wear one of these myself, and I do have a pretty good tolerance with it. Sometimes I wake up and my mouth is extremely dry. I also have small lips and a small mouth, so it's hard for me to get lip closure. But it's saving my life every night versus me having 18 choking episodes a night. With your upper airway stimulation or something that is going to essentially keep it open, a really good thing is going to be a splint or a nose piece. They have some that can be literally made to your anatomy. It's going to hold this open because sometimes you'll have your patient close their mouth and take a really sharp and fast, deep breath in through their nose, and one of their nostrils is going to close. So even if you are getting them to breathe through their mouth at night or through their nose at night, they're only getting half of it because it's not staying open. Another thing to remember is the roof of your mouth is the floor of your nose. So if that patient has a high vaulted palate, it's also obstructing their airway. It's another thing to look out for in your clinical exams. With the surgery, so this is a UPPP is one of the surgeries that is the most well-known. And if you ever see it in person, it will freak you out. It looks like someone took a scalpel and just shaved the back of the throat. This is the last resort. Honestly, it's good if you can qualify for it. It's good if you can get insurance to cover it. It is extremely painful. With this, you still want to present it to the patient though, because they may be like me where they're not completely compliant with an oral appliance or they're not wearing their CPAP all night. We have to give them all of the options. With another thing with orofacial myofunctional therapy. So this is going to be non-invasive. It's going to be a series of exercises that not only strengthen, but repattern the muscles and their use. The one thing with this that happens sometimes is the patients don't commit to the therapy. So even though it's another solution and it's non-invasive, if the patient's not compliant, we have to give them another option. So even though a CPAP might be a great solution, it doesn't always fix the problem. It doesn't fit right, or there's air coming out of the side, and this is obviously driving their bed partner crazy. So we'll go into as well having a bed partner that has a sleep disruption. So they may not have an airway problem, they may not snore, but their sleep is being disrupted because they're being woken up all night every time you start snoring, or their CPAP is too loud, or whatever it is, you're grinding your teeth. Their stages of sleep are being broken because you're waking them up. So it's just as crucial for them. I want to jump over here to these questions really quick. One person was talking about how OSA can mask other issues. So this absolutely can mask other issues. And like they were saying that once they got on a CPAP, they slept better and it revealed a cardiac issue. One thing, even just looking on a patient's medical history, if you see more than one blood pressure medication, it's indicative that the physician is doing everything they can, but they can't figure it out. So they're throwing medication at it. What we need to do instead is start looking at the airway. Airway trumps all. We will be going over medical billing a little bit, and we will be going over pediatric sleep apnea. That will be towards the end. And I believe that's it right now. Yes, I can share the videos with you. A lot of these are eye-opening. It just kind of puts it into perspective. I agree, especially the first one. So we're going to keep going here. The other possible solutions, weight loss. With this, just think about it. If you're laying back and the airway has a ton of weight on it, it's going to make it harder to stay open. That's going to help. But you're also going to go through weight gain as well. We're going to talk about that. A nasal decongestant is good for patients that don't necessarily have an OSA problem or a noteworthy airway problem, but they're still not breathing very well. And in the upper airway, they're having problems. Something like a strip is really good. They're kind of painful to take off, but they do work. I wear them actually. I need to be wearing them more. Again, not compliant. So 96% or more of our air should go through our nose. That's how we get nitric oxide. So in the next thing, sometimes it's just positional therapy. And we find this in after the home sleep test. We see that everything is happening while you're on your back. Sometimes we just need to get you off your back. That does exist. So going into the bed partner sleep disruption more, like I said, just because they don't have OSA or they don't have an airway problem doesn't mean it's not slowly killing them over time. If they're not going into the stages of sleep necessary, like deep and REM, deep is going to be for the body, REM is going to be for the brain. If they're not going into those stages of sleep because we're snoring so loud that we wake them up, their body's not getting a chance to repair and restore.
I can get on her nerves even when I'm unconscious. I've reached that Zen level of being an annoying husband. I'm like a
Here we go.
black belt of annoying husband. Apparently, and I didn't know this, I snore. I only know that I snore because at 3 o'clock in the morning, my wife is screaming at me, I can't sleep like this. I'm like, neither can I with you screaming. Go to bed.
So diving into the symptoms of sleep apnea. A lot of these are, again, we're throwing medication at it. We're throwing all kinds of things that our physicians are doing. We're doing full blood workups. No one's checking the airway first, because if we did, we could avoid all of these things. One thing that I experienced personally with upper airway problems is brain fog, anxiety, depression, where is it? I wasn't obese, but I had fluctuating weight gain. I would lose weight and then I'd gain it back. I'd lose weight and then I'd gain it back. If you see any of these on the medical history, it's okay to just go ahead and open that conversation and say, hey, has anyone ever screened your airway or talked to you about, do you snore? Are you tired throughout the day? Do you grind your teeth? Anything like that. Just open the conversation. So when talking about that, though, so excessive sleepiness during the day is not normal. Taking a nap every day at 2 p.m. is not normal. One thing that I try and get my hygienist to think about and realize, I ask them, how many of you have been cleaning a patient's teeth and it's like 2 o'clock in the afternoon and they fall asleep in the chair? And when they wake up, they're like, you're so gentle. Oh my gosh, I fell asleep. And of course, internally, you're like, dang, I really am. And I'm like, but think about your patient just fell asleep in the middle of the day with sharp instruments in their mouth. It's not that you're gentle, it's they're exhausted. With hypertension, so we're going to be talking more about that fight or flight, that emergency response. Every time the body goes into this, whether it's an apnea or a hypopnea, it causes the heart rate and blood pressure to increase. That's going to narrow the arteries and put them at high risk of blockage, which means high blood pressure, heart attack, or stroke. With the nitric oxide lacking as well because of these constrictions and it being a vasodilator, without nitric oxide, the blood vessels narrow. This goes into having those episodes hundreds of times a night. The heart's exhausted and the body chooses the latter and they have a heart attack or a stroke. Speaking of strokes, so it has been shown that OSA increases stroke risk more than any other single factor. So over 80% of strokes are caused by OSA. Headaches, if you have patients that come in and like, oh, well, yeah, it's because I grind my teeth all night. Now I want you to start thinking, okay, you're grinding your teeth all night because the airway is trying to push everything forward and try and open all night long. I'm going to show you a couple examples here in just a minute as well. Headaches are indicative. We just at least need to screen the airway. I'm not saying if you look at the airway, it's a cure-all, but it is a cure most. I will stand behind that. Nocturia. So wetting the bed in the middle of the night. I don't know if any of you have children in the 8, 9, 10, or around that age, and they're still wetting the bed. It's embarrassing. It's not their fault, and it is highly indicative that they're exhausted and they're wetting the bed because they can't breathe. So this is a really good slide. I would encourage you to take a picture of it. I'm going to read it because there's a couple of people that can't see the screen. But it may trigger nighttime urination by putting stress on the bladder through low oxygen levels and the release of hormones known to increase urine production. When sleep is disrupted by sleep apnea or mouth breathing, we're not getting enough oxygen to our brain, and the body will react and will give priority to breathing because that's what's keeping us alive over other functions like bladder control. Some men will come in and they're like, I have to wake up and I'm using the bathroom like 5 times a night. I'm like, well, do you snore too? Are you tired throughout the day? Yeah, it's because I'm waking up all night and I'm peeing. I'm like, actually, it could be that your body is trying to keep you alive and it's not telling your body to turn off your urine supply.
Bathroom trips in the middle of the night become oh, that is the worst, when your bathroom trips in the middle of the night become movie times. I'm going at 1:30, 2:45, 3:15, 4:45. And if I don't remember to lift the seat, a special showing at 3D and 6:45.
Acid reflux, a really important question to ask your patients if they're having acid reflux problems or you see it on the medical history. Ask them when they're experiencing that acid reflux. If it's during the day, it could be their diet. It could be something like that. If it's at night, that shouldn't be happening, because your body, if it's in the correct stage of sleep, if it's getting adequate oxygen, your body and your brain will know that it needs to cut off that acid production. But also, if it's happening at night, it's because of your abdominal contractions, which I'm about to show you in just a minute, of your airway trying to open, a full collapse, not being able to breathe, and your body is struggling, which is going to push that acid up into the esophagus. That looks like struggling. You can't breathe the whole time because being acid pushed up in the esophagus. And then he finally gets some air. Sexual dysfunction. Everyone gets really awkward and quiet when I talk about this, but it is linked to the airway. If you're not getting nitric oxide and the body narrows arteries because of that and decreases blood flow to all of the areas of the body, including your naughty parts, then yes, it's going to cause sexual dysfunction. It's not getting what it needs in order to do that. Another thing that a lot of people don't think about is nitric oxide is also used to release the egg to complete meiosis. So a lack of nitric oxide means the egg can't be released, which means it's going to potentially cause infertility. If your patients have been on IVF or they can't get pregnant, check the airway. Worst case is I'm crazy and you're fine, but I think it's worth figuring out.
Do you suffer from erectile dysfunction?
Well, Ellen, do you? Jake, what do you know about erectile dysfunction?
Not much. It's something to do with your penis, right?
Right.
And they say 1 out of 3 guys gets it, and mine's fine, so it's gotta be one of you.
Not fine. Me.
Type 2 diabetes. Again, I'm going to read through some of these as fast as I can because a couple of people are saying they can't see the screen. So the presence of recurrent hypoxemia and abnormal nocturnal sympathetic output, which are well demonstrated properties of obstructive sleep apnea. It is going to increase the cortisol levels, which decreases glucose metabolism. And then the metabolism is decreased of glucose contributes to the increased blood glucose levels. With this one, with clenching, bruxing, scalloped tongue, anytime you see any of these, especially scalloped tongue, check the airway. When you see a scalloped tongue, what that is likely from, and it's highly indicative that all night long, your airway is pushing your tongue forward, trying to open, and those indentations are your teeth. And it's happening so many times throughout the night that it's leaving permanent indentations. Cancer, dementia, and Alzheimer's. Severe apnea results in 5 times the number of cancer deaths for those with cancer. So tumors thrive in an oxygen depleted environment. If we don't fix the airway and we're putting them on chemo, we're putting them on radiation, if we don't fix the problem that's feeding the tumor, it's just going to continue. We might possibly miss it. But research shows that people who suffer from poor sleep, constant arousals, and sleep apnea have a buildup of a beta amyloid protein in the brain. Again, my 2 mentors, Rebecca Leahy and Dr. Carolla, are going to roll their eyes right now. I know they're watching, but I call it the dishwasher effect. So when we go into that stage of sleep, basically your brain goes through a motion where it washes all of these proteins out of your brain so they don't build up and essentially eat away. So if that's not happening, that's just building up and building up and building up. If you look at a scan from an OSA brain and a brain with Alzheimer's, they look identical. One just looks worse than the other. If you're unplugging a dishwasher to get, something out because you need it and you close it and then you forget something else and you're doing that all night long, how clean do you think those dishes are actually going to be? We talked about weight gain a little bit, but I'm going to get into what it actually is. So lack of energy, slow metabolism, and changes in your hormone is what is going to cause weight gain because of OSA or an airway issue. Those combine to make you want simple carbs and foods that are high in sugar. If you're reaching for unhealthy sugary foods, you're going to gain weight. It's going to cause other health problems such as high blood pressure. But another thing is when you don't get enough sleep, your body's production of the hormone leptin is interrupted. So leptin is a hormone that tells you basically that your stomach is full after you eat. So if you're waking up hungry, it's probably something that we need to check out because you shouldn't be. Also, the production of ghrelin is the hormone that causes you to want to eat more, and that's going to be increased. So high levels of ghrelin means that you're increasing your eating and you're gaining weight. Medical billing, I am going to hit on this as high level as I can. Here is my advice. I'm not going to give you a specific medical billing company. I am not going to do that. But what I will tell you is until you become the expert and you know how to get paid backwards and forwards, hire someone to do it for you. Don't put yourself in a corner with your hands behind your back and not get paid. You're going to get discouraged. Your patients are going to lose trust in you. They usually only take 5 to 8% of whatever you get paid for, and they don't get paid until you do. So until you can learn it, pay someone else. You're not the expert yet. It's okay. But don't fail before you even get started because you're worried about your ego or you're like, I can do it myself. I don't want to lose this money. It's not about the money. It's about saving the patient's life and also encouraging you and getting you paid so that you continue to do it. This is the last section. We only have a few more slides and then we'll open up the Q&A. I just want to let you guys know with pediatric OSA, as I was telling you guys earlier, we need to catch it in those early formative years so that they don't grow into a full-blown patient with an obstructive airway. Sorry, guys, the fire truck's going by. 1 second. So usually this is because of enlarged tonsils, which I'm going to show you in just a minute, and the adenoids. So back in the 90s, they stopped covering tonsillectomies. They stopped covering removing the adenoids. Now we have all these adults with an airway problem. Guess when they were born, when everything was not covered. Often you're going to see in children who are smaller, they're going to be less developed. They're going to be underweight because of the disruption in the nighttime secretion of the growth hormone, little guys, or their face is going to start looking asymmetric. They're going to have bags under their eyes, dark circles, especially if they have any of these things. So if they're still wetting the bed, ADHD, they have a forward head posture, large, but they're not infected tonsils. All of these things are indicative that they're exhausted. They can't breathe. How do you perform if you wake up and you haven't gotten any sleep? Of course, they're waking up angry because they're not getting anything that they need in order to grow. This is a good example of what we call closing curtains. It's something that you want to look at if your child or any of your pediatric patients are experiencing any of these problems. Take a quick check at their tonsils. If they are coming together, and we call it kissing curtains, kissing tonsils. If they're coming together, the closer together they are, the less air that's going in, the less oxygen they are getting. Anything that is remotely around a 3 or a 4, they need to be referred so that you can have those tonsils removed. I would encourage you to find an ENT that is airway focused because not all of them are. In very severe cases with any children, a CPAP can be prescribed, but there's other things that we can do first, like palatal expansion, myofunctional therapy, removing the tonsils, removing the adenoids. All of these things can solve everything before anything serious happens. Last video, and then we will be all done. All right, guys, I am going to keep going here. This is getting towards the end. One thing I will tell you guys, and I am going to stay on and answer as many questions as possible. I am here for you. Learning Airway in an hour like this is basically drinking water through a fire hose. So I will stay on here as long as you need, and whoever wants to stay, please do. One thing about this is we all have to start coming together and doing this as a team. It's not about who has the best product. It's not about who has the best medical billing. It's not about who makes the most money. It's breathing versus not breathing. It is so serious. And until we start working together, we're not going to help as many patients as we should. It's that simple. If you would like to connect further and continue the conversation, if you want any of the slides, or if your questions are not answered here next, go ahead and scan that QR code. It's going to give you all of my information. It's also going to make it to where you can make a Zoom call with me so we can talk further. There's going to be more courses later in the year that I'm going to be doing with my company that I work for. We're also diving into Airway as well. So we're going to be able to create more of more education, more time. I am going to go over to some of these Q&As, but also a couple of people were asking to see some other slides. So I'm going to go back to those now. There, I believe you're speaking of this slide. And so with this one, take a picture of it if you need to, if you want to talk to any of your patients in a pediatric office and you need to show this to the parents. It's a good thing to go over with them. Another thing with the dark circles is, again, that lack of oxygen. They're exhausted. And when you actually put them in therapy and you actually start to solve the problem, their face lights up. I can send you pictures if you'd like to see them, but they look like a totally different child. Another one is, sorry, 1 second. Another question is, would you, or I would like to know what we can apply from this great lecture into our dental hygiene appointment. This is what it is. I will tell you right now, you are staring at this all day, every day. And a lot of hygienists, myself included, we come out of this rigorous program. It's hell. If any of you have done it, you know, and we don't even know what the word mal and potty means. We're staring at it all day long. Check for this. Remember to sit your patient up, Look at the medical history. You can tell a lot just from there. If you see more than one symptom that I showed you just a minute ago, anxiety, depression, more than one blood pressure medication, daytime sleepiness, acid reflux, don't forget to ask them, when are you experiencing that acid reflux? If you have older men and they're saying that they're going to the bathroom all night, and okay, let's ask them a couple more questions. But this is going to be one of your biggest tools that you need to have in your toolbox. It takes seconds. If you're working in an office and they're not implementing Airway just yet, what I used to do when I was a clinical hygienist, I was a travel hygienist, so I was in a different office every day. When I found a patient like this, I couldn't ignore it. I can't do that. And like I said, I don't allow room for politics and breathing. But I would ask them for their zip code, and I would get on Google and I would type in dental sleep medicine dentist near whatever their zip code is. Write that down for them, tell them to call that practice and ask for a home sleep test or at least a consultation. Let them know worst case scenario is I'm crazy and you're fine, but I think it's worth the $100 to $200 it's going to cost you to get an accurate representation of what's happening every night when you go to sleep. Another one here, let me just make sure. We talked about medical billing. Like I said, it's not who you should hire. It's just that in the beginning, respectfully, you're not the expert. Hire the expert. Let's get you paid in the beginning so you can build confidence. You can build a good program with your office and get the team on board. And then by all means, hire your own medical in-house biller. But until then, don't do that. You're starting with your hands behind your back. And yes, I will send that video for you. I'm going to go over to the Q&A. How does the oral appliance you wear differ from a snore guard? An oral appliance is going to protrude the mandible and possibly, if the patient needs it, also open them up vertically, and it's going to hold that position in place. What that does is it keeps the airway open all night. So with a snore guard, like I showed you, and I'll pull it up one more time, putting them in a flat plane splint, which is what the snore guard is, you're putting their airway on a skating rink, because since it's flat, the teeth are going to be doing this all night long. So the airway is now going to struggle even harder to stay open. I have some patients wearing CPAP and an oral appliance. Their airway is larger in volume with the mandible forward, which results in less airway resistance, which means the CPAP pressure can be reduced, resulting in greater compliance. Absolutely. If that's what works for that patient, it's something called dual therapy. Sometimes that's what they need. That's okay. Again, keep that mindset of what will the patient be the most compliant with. We need to have every single option there is out there, which means we have to keep getting ourselves educated so that we can get all of those options to them. They deserve that. Will this be recorded later? I would love to see this again. So Catapult Education will, to my knowledge, it will be on their YouTube page for you to rewatch. It will be on demand. So yes, it is recorded. And if you need to share it with anyone, we'll be happy to send you the link. So there's a couple of questions in here about myofunctional therapy. It's not that it's controversial. I know that there is controversy about it. It's compliance. The patient has to, and I'm looking for the slide here really quick to pull up for you. The patient has to commit daily to time for myofunctional therapy. I'm going to tell you right now, I would be the worst patient for myofunctional therapy. My myofunctional therapist would probably fire me because I'm not going to be compliant. I honestly need something more permanent, like maxillary expansion or surgery, something that I don't have to worry about being compliant about. So if the patient is not doing what their myofunctional therapist is telling them to do, no, they're not going to get the outcome that they would if they committed to those exercises. So I wouldn't necessarily say that there's controversy. It's just, you can't follow the patient home and make sure that they do this every single day. That's how you end up on the news. So it's, you know, you can only do so much. try possibly educating them more on, what would come out of them committing to these exercises, maybe help motivate them some more, or maybe they have some questions that they're not asking you. Sometimes we have to open the floor up for what our patients are scared to ask us. With male and female patients, it's not one or the other, but sometimes they'll come to me and they'll ask, well, I snore, but I don't want to tell my husband, or, my wife snores, but I can't tell her that. There's things like a bed partner questionnaire that you can find in numerous places online. I can send some to you as well, but you can print that out and open the floor for their bed partner to fill out what's happening with their husband or wife, because let me tell you right now, your spouse will rat you out in 5 seconds. So it is going to give us a more accurate view on what is actually happening. Is a snore guard good for bruxism? No. If they're actually having an airway and you need to check that first, at least screen them. And then if you're still a little unsure because they have other things, like they say they snore, or they say they're tired or nap throughout the day, any of those other symptoms, anxiety, depression, then you need to get them a sleep study. Worst case scenario is you find out that they're getting way too much light sleep. Okay, what does the patient's sleep hygiene look like? That could be causing the light sleep being too vast in that chart, because if you're staring at blue lights all night before you try and go to sleep, if you have lights on, if you have the TV on, if it's hot, if it's not dark, your brain does not think it's time to go to sleep. Your brain thinks it's time to go do whatever, you usually do when you're that active. So I would say the primary thing is get that sleep study, get an answer so that you can give it to them. But honestly, in most cases, that snore guard is going to make their bruxism worse on one end or the other. It depends on the type of snore guard that you use. The oral appliance, the mandibular advancement device, would be better, especially if there's an airway problem, because you're protecting their teeth. You're no longer getting the stress on the teeth, and you're keeping their airway open. So fixing the entire problem instead of just putting a Band-Aid on a broken bone. Okay, there's a few more in here. And by the way, guys, if any questions, please bring them in. I am going to stay on here as long as I'm needed. Here it says, the biggest issue is that the patients need to see the right dentist and the right orthodontist. Most of us still are not on board and don't understand that we need to be saving lives. Same is true for physicians. So we stay tooth focused. So here's the thing. Once you're educated and once you know that there is a problem, please, even if you're still not on board, please screen and refer. Say what you see. If you see that you can't see down their airway, if you see that they're on more than one blood pressure medication, say what you see and refer them to someone that is on board and ready to take on that responsibility. But just staying tooth focused, as easy as it is, and we're still doing incredible work when we do that, we're ignoring saving their life, especially if we know that there's an issue. But I do agree with you. They need to see the right dentist. They need to see the right orthodontist. Not every orthodontist is airway focused. A lot of them are now, but there's still some that are not. They're extracting premolars and narrowing the arch. And like I said earlier, the roof of your mouth is the floor of your nose, and that's your airway. So if you're making the maxillary arch more narrow, you're closing the airway. It's that simple. The kids that get missed as having sleep airway issues, if they are auditory learners because they don't have to study, get grades, but are always tired. Yeah, I agree. I think that they are missed because there's not as much to look for, especially being auditory learners, but you'll be able to see it on their face. You'll be able to see it in their behavior. If they wake up and they're just mad at the world, I would be too if I was choking all night long, or if my tonsils were kissing each other and there was no air coming down. So luckily, there's other things that we can watch out for. Wetting the bed until they're 10 years old, not being able to go sleep over at a friend's house because they're embarrassed. Check their airway. It takes seconds. Have your child stand in front of you. Ask them to open up wide. They don't have to stick out their tongue, but if you can't see back there, another problem, but if you can't see back there and see the tonsils, ask them to stick their tongue out so that you can and say, especially then if those tonsils are even remotely close to each other or completely touching, they are not getting oxygen at night. So one attendee said, regarding myofunctional therapy, taming muscles is said by many not to work. Muscle control is very, very hard. Thanks for your opinion. Yeah, I mean, it's hard to commit to some of these things. I even with my oral appliance, and Dr. Carollo, if you're listening to this, I'm sorry. I do wear it, but I don't wear it like I should. I don't take it everywhere, or I fall asleep because I'm too tired and I didn't wear it the night before, and it's just this endless cycle. Same goes with myofunctional therapy. If they're not doing the exercises every day, and it does have to be daily, they're not going to get the benefits from it. Those muscles are not going to be tamed. They're not going to be strengthened because they're not doing the work. So we have to find another solution to them regardless, because they are choking every single night. They are dying in their sleep every single night. We have to let them know that. One question says, how does TMD fit into OSA? Does one cause the other? So it's kind of like which came first, the chicken or the egg. It's hard to know unless you've been monitoring that patient since they were a child. If there is an airway issue and they're also complaining of TMD, where the disorder of the TMJ is happening and there's pain or clicking and popping, it's highly indicative that it's from the airway, because those muscles and your jaw and everything in that region is working hard all night long and putting so much stress and so much pressure on those muscles. So it can absolutely cause a disorder with the TMJ. And they're going to answer you guys on where and how to get the CE certificate. Just going through some more of these. These are great questions, and I am still here. I will still answer any of them that you have. Yes, I can send you the slides if you'd like to share this with your office. I highly encourage you to get the on-demand course and play it during your lunch hour or something like that. Once you see and learn about airway, I'm sorry, you're welcome, but I'm sorry, you're going to be seeing it everywhere. You're going to see scalloped tongues. You're going to see children that look like they're exhausted. You're going to see people on airplanes sleeping with their mouth wide open, and you're going to be like, do I go over there? Do I not go over there? Do I let them know they're dying in their sleep? Another myofunctional therapy question about the controversy, but this one is the issue of compliance of 4 to 8-year-olds. It's hard. We can barely get our children to brush their teeth. Asking them to commit to daily exercises can be really hard. But if you have a very motivational myofunctional therapist, and there are so many, if you need referral to any, I have tons of them. They are amazing. I don't have children, but I would trust them with my children if I did. They present it in a way that, one, the child understands, which is really, really, really important. They break it down to them to make it easier for them to do. It's not going to take up as much time. It's going to motivate the child to do it. But until your child is able to take care of themselves, the parents have to step in. This is more your responsibility than it is your child, especially between 4 and 8 years old, especially if they're exhausted. They're not thinking straight. They're not getting oxygen to their brain all night. They're like struggling to even focus on things at school, or they're falling asleep at school. Like the video that you saw at the very end, it was the bully of the school, and then everything turned around. So it's really, really important to keep that motivation with children and get them to understand it, get down on their level so that they understand the urgency with this. There's ways to go about it, and having a really good myofunctional therapist will make a difference there. One of the questions is asking about a child's arch space. So look at the palate, number one, and I'm not sure if you're asking about which arch, but a good way to tell is looking for that high vaulted palate. If they have a high vaulted palate, they're getting either decreased or barely any air through their airway, which is going to be in their nose, because if that space is being taken up by the roof of the mouth, everything up here is constricted. They're not going to be getting nitric oxide. They're not going to be getting anything. So definitely look at the high vaulted palate. Look at both arches to see if they're narrow, teeth crowding, anything like that. If they have, we have some hygienists that have come to me and they're like, okay, well, I have a patient and the anterior teeth look really, really, they look clean, but the tissues are really, really irritated. They're really, really red. And then in the posterior region in the back of the mouth, everything looks healthy. I said, you need to check their airway, because if they're sleeping with their mouth open all night, that's where that's going all night long. You're creating the perfect environment for bacteria to thrive in a very specific part of the mouth. If you're just not checking the airway and you're just treating for gingivitis, it's never going to go away because you're not actually curing the root cause of that gingivitis. I am so glad that this helped a couple of you. You're talking about, I have children that need to breathe. And I was that child. I had ADHD, and growing up in high school and college, I had anxiety. And if I had my thyroid tested one more time, I was going to cut it out and hand it to them. Like, it's not this, test something else. It wasn't until I started working a few years ago with an Airway company, and they wanted everybody to get a home sleep test. And our director of education at the time called it to the number of what or how many choking episodes I was going to have. And she was like, you've had this since you were a child. And had it been caught then, you wouldn't be here right now having these issues. It would have been fixed. My face is asymmetric. This is a little bit too much about me, but I had lip fillers done like 6 months ago, and I saw the before and after, and I was like, I'm mad at all of my friends. They were letting me walk around with uneven lips this whole time. Like, it's because I wasn't getting adequate oxygen during my formative years. And that's how you can see on people's faces, it's asymmetric. It's not lining up the way that it should be. So I highly, highly, highly encourage you, especially if any of the children have tongue ties, getting an evaluation to have those released, anything like that. It's very, very crucial to catch it in the formative years. Someone else said the success of myofunctional therapy and tongue exercises hinges on the parents. I do agree. Of course, kids don't want to do something like this. It requires them to sit still for the exercises. So we don't want to make myofunctional therapy sound like it's hard to do or a drudge or anything like that, because I agree, it isn't. If it's going to be something that the child is not going to do, that's what I'm saying. It needs to be, okay, this isn't working for this child, and I need to figure something else out. That's okay. Again, it's about the patient. It's not about which therapy is the best therapy, because it's not one shoe or size fits all. That's not how it works. I'm proud of you. One of the attendees is saying they're going to be more proactive starting tomorrow. All of you can start. If you're practicing clinically still, you can be proactive. Yes, starting tomorrow, you can start screening, checking that medical history, asking certain questions. If you see certain things on the medical history, checking them all in potty before you sit them back. All of this can be done before any therapy comes in. Screen and refer, say what you see. That can save a life alone. Even if you don't have the capacity to treat anything just yet, we still can catch it. Can you please indicate your opinion on a 6-year-old who has allergies to walnuts, had a tonsillectomy and adenoids removed, somewhat incompetent lips and gummy smile, sleeps with lips slightly apart, seems to be daydreaming and doesn't always follow with request, no bedwetting. What is your advice? So if the tonsillectomy has been done, the adenoids have been removed, is the arch top or bottom or both? Is it crowded? Also, if they're not having that lip closure and they're not learning at a very young age, if you see them sleeping with their mouth open, just slowly close it. Anytime you see it, or go in and check on them at night, close it, because if they're not getting that nitric oxide, their body is not getting what it needs to repair and restore. Also, with the gummy smile, if you're saying that they're sleeping with their lips slightly apart, that's slightly enough for it to be considered mouth breathing. So even though they had the parts that were causing part of the problem removed, there's still other things that can cause this issue. No bedwetting is good. Daydreaming, yeah, the fog brain that you saw on the symptom chart that I have here. Brain fog is a very real thing. It's like, the way I used to describe it before I was wearing an appliance and knew any of this stuff, is like someone had a veil over my face. And once I started actually getting what I needed wearing that appliance, it was like someone took it off. And I had no idea that that was something that wasn't normal, because I've been that way since I was a kid. I thought having a veil over your face and having brain fog was how you live your life. And if we're not educated, we don't know what we don't know. We can't fix it. These things are not normal, and we get to fix them. So I would definitely make sure that we are screening for any crowding, the sleep patterns, if they're sleeping with their mouth open, things like that. Get an airway focused dentist or orthodontist if there is crowding, so that it can be fixed. There's a couple of other resources that I can refer to you offline. There's a new company that literally only focuses on treatment for children. So I can help you there as well. They're new, and it's incredible what they're doing. It doesn't mean they're not smart. It just means that they're too exhausted to think. They're too exhausted to care. Sometimes they come across as the kid that's bored or not paying attention in class, or the kid that can never sit down because they're so hyped up, and they're just hyperactive from being like that all night long and going into that fight or flight all night long. It presents as that, it really does. There's so many different things that you can pay attention to. A couple of people have their hand raised, and we can continue the conversation. If there's some things you'd like to ask me offline, I'm happy to answer them. You can also, in the chat, she posted my phone number. You can text me if you call me and I don't answer. I'm probably working or sleeping or something like that, but text me and I'll let you know. You can also email me. It's going to be Loren@viome.com. That's Loren. That's going to be the fastest way to get me. I have access to that all day long at work. And then a lot of people reach out on Instagram, yes, as well. My handle is Loren the Activist, Loren, and I would be happy to help.